I am going to talk for the next few minutes on exercise therapy and injections in osteoarthritis, particularly viscosupplementation. Now, we have talked about progression of structural damage in cartilage, and we have talked about some certain drugs which might prevent this so far. But we now come to the stage where if some structural damage has already happened, then what? So these terms have been vaguely referred to as early osteoarthritis in the literature, and vague knee pain has often been described as chondromalacia. So chondromalacia is when the surgeon does not really know what the structural changes, but the patient has problems. A more appropriate term which has emerged and which more scientifically describes early cartilage pathology is chondropathy. So with the emergence of cartilage scanning MRIs, we now very well define chondropathy and would not refer to anything as chondromalacia, because chondromalacia would signify that the surgeon doesn't know what's happening. Now, of course, again, we still can do other therapies apart from medical therapy before the structural changes come up. And indeed, the evidence has been in exercise treatment. Now, you might consider exercises in the form of physiotherapy, particular exercise which people assume with sports or at the gym, and people are also advised limitation of certain activities, modification of some other things, and so on and so forth. Now, all of these things work if they are done in the right perspective. What clearly doesn't work or has very less compliance is use of braces in the long run, because these braces really would only work as pressure and lead to muscle wasting. I must mention yoga and early naturopathies, which have taken origin in our country, and with the acceptance of one of our colleagues, Professor John Ebenezer, as an awardee at national level, this has actually even been recognized and put forth in the AAOS recommendations. We should hence be proud here. Now, in terms of exercise therapy, a lot more new treatments are emerging, and we ourselves in Bangalore are researching this particular one, where we make a patient stand on a force plate. These are people who documented early osteoarthritis, and we see a measure of their proprioception. That is a plot of their center of pressure, which the force plate plots over a 30-second period, and variance of that suggests that their proprioception is bad. Tackling proprioception at an early stage is known to be actually helping them better. And that's what we've actually devised an algorithm and got a prize at a innovation conference at India level. Anyway, so there is also role of traditional medicine. There are various kinds of chondroprotectives which are not available. And I won't go too much into the details of this. But along with that, there are known and rightly popularized different injections treatment in the knee. Now, classical and time-tested is steroid, which works well in inflammatory flare-ups. And what I'm going to talk about today is hyaluronic acid. There's, of course, the new kid on the block, which is PRP, and that will be touched upon by my colleague later. So hyaluronic acid is actually a component of the synovial fluid. What we are trying by means of the injection is basically trying to restore the balance, give it some better lubrication, and we also know that it probably works in anti-inflammatory as well as nociceptive modes. Now, there might not be a lot of evidence. The evidence here is basically that the drug is safe to use. However, it has not been recommended by the international societies. Now, despite this, there are various indications in patients who desire to delay operations, who would rather have some intervention, actually find popular usage for this particular thing, even though it may not find acceptance in many insurance companies across the world. The important thing to note here is it is not just recommendations, but if it helps patients, and it does help a large number of patients, as long as you do it safely, it does have a role. And the side effect profile really is minimal. It can be used very much on its own. It can be used in combination with steroid or in combination with PRP, especially to reduce the inflammatory effects related to the white cell components when we put PRP in the knee. So PRP on its own can sometimes create a septic arthritis type of reaction, whereas HA addition will actually prevent that. And HA also acts as adjuvant therapy and as a substrate when cell therapy and cartilage regeneration is done. So there's multiple usage there. The theory in different types of HA, this is a busy slide, but just to drive home the fact that there are many preparations available out there. What has, if I had to summarize that, there are ones which are AV, of course, very popular, and the newer ones which are essentially recombinant DNA technology from microbial sources. These newer ones would have a lesser side effect profile because they are not proteinergic. Now, the higher molecular weight ones are known to be better in terms of longer lasting. The earlier lower molecular weight ones had to be repeated and are therefore going out of vogue because repeat interventions would put a knee prone to development of infection. However, with adjuvant treatments, one would have to go the science says with evidence that low molecular weight goes better as adjuvant when you use it in combination with PRP. So that's in a nutshell about these two exercises.